Stel je over daar. En de paardenimfen mogen hier zitten. Er is een glas water voor u. Ja, oké. U kunt wel plaatsnemen. Yes.
Dear Mrs. Li, I would like to welcome you for your defense this afternoon. And I officially open here this academic ceremony in which Mrs. Li, I'm going to say, will defend her academic thesis entitled Lysosomal Disturbances in Metabolic Disorders. I would like to invite you to present a summary of your studies and the conclusion of your thesis in the next 15 minutes. And I'd like to give you the word.
Thank you, dear Prorector. Dear Prorector, members of committee, colleagues, friends, and family. Today, I would like to share with you the summary and main findings of my PhD thesis. In this thesis, we looked at lysosomal disturbances in metabolic disorders. To understand this, I would like to start with what is a lysosome. A lysosome is a functional part of the cell that has an acidic environment, and it's filled with the enzymes. These enzymes can digest and degrade the things inside the cell, which are then used for energy or building materials for the cell. For example, lysosomal enzyme cathepsin D, a protein is, which is responsible for degrading proteins. Another lysosomal enzyme, acid phosphatase, a hydrolase, which breaks down the ester bonds present in lipids. Lysosomal function can be negatively affected by drinking too much alcohol, eating too much fatty food, and genetic mutation. When this occurs, you get lysosomal damage, which leads to the leakage of enzymes into the blood. Lysosomal dysfunction is associated with metabolic disorders, which we will cover in this thesis. I will now give a brief overview of metabolic disorders covered in my thesis. In Chapter 2 and Chapter 3, we covered alcohol-related liver disease, ALD, which results from consuming too much alcohol. In Chapter 4, 5, and 7, I covered metabolic syndrome, MET-S, metabolic dysfunction associated steatohepatitis, MASH, and hepatocellular carcinoma, HCC, which results from overconsumption of fatty food. Finally, in Chapter 6, I cover NPC1 disease, which results from genetic mutation. Those various metabolic diseases have one thing in common. They all lead to liver complications, as I will explain further into this presentation. The main focus of the study in this thesis was to investigate the use of lysosomal enzymes for diagnosis and treatment of metabolic disorders. We are not covering all chapters in this presentation. We will focus on the chapters below. The first two studies, I looked into lysosomal enzyme cathepsin D in the context of alcohol-related liver disease. The third study, I looked at lysosomal enzyme acid phosphatase in the context of metabolic syndrome. Finally, the last study focused on targeting lysosomal enzyme cathepsin D in the context of MASH. The first disease I will introduce is alcohol-related liver disease. This happens when people drink excessive amount of alcohol, which leads to fat and inflammation built up in the liver. In long term, this leads to liver cirrhosis and ultimately liver failure. It is currently challenging to diagnose ALD early. To address this issue, there is a need for a simple, non-invasive way to detect ALD. In the past, in our group, we investigated that the lysosome enzyme cathepsin D is associated with some metabolic disorders. However, there is no data on cathepsin D in the context of ALD. So in this study, I investigated whether cathepsin D can be used as an indicator in diagnosis of early ALD. So for this study, we have two groups of patients who drank excessive alcohol. One group without liver complication, one group diagnosed with ALD. Through a liver biopsy, we took blood from patients and measured cathepsin D. In the result, we found that cathepsin D is increased in ALD patients compared to healthy. Next, we also analyzed diagnostic ability of cathepsin D to distinguish ALD and healthy. And we found that cathepsin D has the highest diagnostic ability with 80% compared to the other two currently used diagnostic marker for liver disease. Therefore, in conclusion, cathepsin D could serve as an early indicator of ALD. As previous studies shown that cathepsin D significantly increased in early stages of ALD. In the next study, I further investigated whether and how it changes in the late stages of ALD. So for this, we used a group of advanced ALD patients with liver cirrhosis through a liver biopsy. Similar as the first study, we measured cathepsin levels in patients' blood. Surprisingly, in the result, we found that cathepsin D decreased with the severity of liver disease. In conclusion, cathepsin D decreased gradually in the advanced stages of ALD. As previous two studies shown that cathepsin D increased during early stages, yet surprisingly, it decreased in the late stages of ALD. This could be explained due to the presence of extreme liver damage in the late stages, which results in less viable liver cells, and then less secretion of lysosomal enzyme, including cathepsin D, comparing to this in early stages. As mentioned in my introduction, the diet, namely overconsumption of fatty food, also can lead to metabolic disorders. The first of which is metabolic syndrome, which occurs when people eat too much fatty food and do not exercise efficiently. This could lead to metabolic syndrome, and in the long term can lead to which is a risk factor for cardiovascular disease, diabetes, and MASH. The second is a MASH, a liver disease, that can result from a metabolic syndrome. If no lifestyle changes occur, the liver builds up too much fat and can further deteriorate as it becomes inflamed. In the long term, can lead to liver failure. So the next study I did was in the context of metabolic syndrome. Why the diagnosis of metabolic syndrome is well established in adults. It is currently challenging in adolescents. This is due to the growth and hormone changes, which have an influence on the diagnostic parameters. Currently, it is known that lysosomal enzyme acid phosphatase is associated with a metabolic syndrome in adults. However, there is no data currently available in adolescents. Therefore, in this study, I investigated whether AP can be used as a parameter to assist with detecting metabolic syndrome in adolescents. To achieve this, we have two cohorts of adolescents and adults with obesity. These patients have divided into two groups, one with metabolic syndrome, one without metabolic syndrome. Similarly, we measured AP activity in the blood, and the results showed that AP is increased in metabolic syndrome compared to non-metabolic syndrome. Additionally, AP was strongly associated with a triglyceride, which are lipids in the blood. Finally, we also detect the predictive ability of AP, and the result shows that plasma AP activity has the potential to detect metabolic syndrome. As previously mentioned, metabolic syndrome is a risk factor for development of MASH. Currently, it is challenging to treat MASH, and so additional therapeutic options are needed. To this end, I looked at cathepsin D inhibition as a strategy to treat MASH. Previously, in our group, we did an in vivo study where we used mouse, fed a high-fat diet, and then split into three groups. One group received control injection, the other two were treated with inhibitors that specifically block cathepsin D, that is present inside the cell, intracellular, or outside the cell, extracellular, respectively. In this study, the results showed that there were no effects of intracellular treated group in lipid content, although the inflammation was slightly reduced. Remarkably, the extracellular treated group had a significant reduction on both liver lipid content and inflammation. To understand this result, I performed a lipidomic analysis to see what the difference there were in lipid content. Additionally, I also looked at oxidative stress, which is a marker for cellular damage. The results showed that extracellular inhibitor-treated group had increased good lipids, which are associated with reduced inflammation. And also, extracellular inhibitor-treated group had reduced bad lipids, which are associated with mitochondrial dysfunction. Finally, extracellular cathepsin inhibitor-treated group had little to no detectable oxidative stress. In conclusion, extracellular cathepsin inhibition has potential therapeutic benefits in the context of MASH. In this presentation, we showed that lysosomal enzyme cathepsin D and AP can detect ALD and metabolic syndrome, respectively. Additionally, blocking extracellular cathepsin D led improvement in treatment of MASH. And so, in conclusion, lysosomal enzymes play important roles in and are promising targets for diagnosis and treatment of metabolic disorders. Thank you for your attention, and I'll give the word back to Prorector.
Thank you very much, Mrs. Li, for the very clear presentation. Nice drawings. I don't know if you make them yourself, but they were making very nice, very compliments for that. So we're going to start officially with the deliberation, and I'll ask first, does everybody hear the candidate well? Is the microphone correct? Because I see that the microphone is behind the computer, maybe it should be more in front of her. Can you check that? Here. This thing.
You mean the
mic is behind.
The mic is behind, or not?
I don't see a mic.
Okay. Then I would say, Joshua, can you bring the mic a little bit higher? You can do that maybe there. Okay?
There is no microphone in the room for the candidate. We only have a microphone for the online opponent.
Okay. So there are no microphones here available. Okay, thank you very much. Then we're going to continue, yes? And first, before we start, I'm going to introduce to the audience and to the members of the Corona your promotion team, very briefly. And these are the people, the scientists, who brought you in 4 years to this point where you're going to defend. And I would like to welcome first Dr. Westerterp. She is associate professor. I don't have the department, but I know it's from Groningen, and I would like to welcome you. And I notice you're here, not online, so you took the effort to come all the way from Groningen to Maastricht, which is a long train ride. And I thank you for that, and that you took this opportunity. I would also like to mention Dr. Hauben, who sits here on the opposite. He is involved with the Department of Genetics and Biology at our university. And finally, the first promoter, Professor Shrivri Svetlov. She is from the Department of Hepatic Inflammation and Metabolic Health at our university, and I'd like to welcome them all. So without further ado, we're going to start, and we have 5 members in your Corona, and 1 member is online for the audience too. You will not see them because he will appear on the screen behind you. And like we do normally here at Maastricht University, the opposition will be opened by the chairman, I should say, of the assessment committee, and I'd like to give the word to Professor Olte Damming. He is professor in surgery at our university, and I give you the word for discussions.
Thank you, Mr. Pro-Rector. Dear candidate, I really enjoyed reading your book, and I would like to congratulate you on the nice work that you did, and I also want to express my congratulations to your promotion team that helped you doing that. My first question will be, because you described some studies in your thesis, which of these studies are you most proud of? And can you tell me why you are most proud of that study?
Highly esteemed opponent, thank you for your compliment and your question. So in my thesis, if you ask me the most pro-wide study, I would say that chapter 2 maybe, cathepsin D could be used as an early indicator for ALD, because currently it is difficult to detect ALD early, because if for advanced ALD detection is already mature and well established, so no need to for the diagnosis of advanced. However, if patients do not have a liver complication during the early ALD, it is an urgent need to find a non-invasive biomarker to detect it earlier. And in our study, I think the data are quite promising to show that cathepsin D could be a potential indicator for a non-invasive biomarker in the blood.
It's for the people that drink a lot but don't have the problems yet.
Yeah, not yet. Being liver damage.
Limburg will like that part, but I know that 2 of the opponents will ask you questions about that chapter. I'm going to ask one of the anonyms to read out loudly proposition 3.
The inhibition of extracellular cathepsin D has potential benefits for the treatment of MASH.
So in the statement you say potential, and it means that it's not really strong, your message. But I would like to go with you to chapter 5. In the last sentence of the abstract, you're very strong in your statement. Because in your last sentence, you say the observed modifications demonstrate the clinical advantage of the extracellular. Can you explain me in your study how you can draw that conclusion that it has clinical benefit?
So in this study, we performed beneficial of extracellular cathepsin inhibitor on in vivo mouse study. We see the potential benefits that because this inhibitor has not been used in clinic, so still need to do the further studies, still need to test it on patients to do some preclinical models.
Okay, so you can't show the clinical benefits in
No,
this study.
Yeah, but we say that potential.
As potential,
you
yeah.
need
So you
to
can-
test. Yeah.
So I will consider this as a statement, and you agree with me that this is
Not yet. Yeah, I agree with you.
too bold, huh?
Yeah,
So
yeah.
let's go in that chapter to page 119. And there you show the only histology figures with normal staining. So this is the intervention group, you have the placebo, and then the conclusion is that the extracellular inhibitor is better. Where in your study do you show, hard data without the mass spec imaging that on histology the extracellular inhibitor is better?
Yes, we did have a paper already published before, also from our group,
Yeah.
the same model, and we did show the improved.
That's what I thought. So
Yes,
your
possible.
data are referring to a
The previous
study.
Yeah,
So this is
histological.
only the molecular fingerprint used by mass spec imaging.
Yes.
So that is also, I found it very difficult to read when I was reading this chapter.
Yeah, I can.
Now it is explained.
Yeah.
Okay, so the clinical benefit. Can you explain me a little bit about mass spec imaging and what the problem is with mass spec imaging if you want to quantify lipids?
So I think for mass spectrum, this technique is used for detect molecular to device lipid composition and also can detect spatial distribution in the tissue. In our case, it's a liver tissue. However, if you see the we did quantification and we did see some enrichment of a specific lipid content.
How did you do the quantification? So how do you quantify mass spec imaging?
So for this technical part, I do not know. That's we collaborate with
Berta, I saw it.
Yeah.
Normally you do it by the intensity of the ion beam, so you normalize it. That is what I always find difficult with mass spec imaging, because you ideally would like to have an internal standard like you do with other techniques with mass spec. So you tell me there are good lipids and there are bad lipids. What is the evidence in humans that these are good or bad lipids?
So in our case, bad lipid, good lipids like PC or PG. So in this study, we actually did not do the experiment to show actually effect of this good lipids or bad lipids upon inhibitors. We just looked up from literatures what is properties and functions of those lipids, show that in MASH or metabolic.
These studies, were these studies association studies with the good and the bad lipids, or loss and gain of function studies proving the mechanism?
I think both. Some of the also function. I think, for example, PG has the anti-inflammatory properties that quite function lipids.
Okay. So you probably made use of a study that was done before, or did you do the study yourself? Probably somebody else, huh?
So for mass spectrometry study?
No, I mean the animal study. So the slides. Was the experiment, did you do it yourself?
Yes, slides I did myself, but
The
for
slides, but the experiment, did you do it yourself?
experiment previous PhD did, we have the materials.
It's not in the results, but did all the animals survive the period of intraperitoneal injections? Was there a dropout of the animals?
I think inject animals every 2 days for 10 weeks.
I know only 3 animals per group. Huh?
Oh yeah, I mean yeah. So that one of the limitation, we only pick up 3 animals per group for this study. But commonly in other studies, they also use 3.
But they all survived, probably.
Yeah.
Okay, I see the boss nodding, so that is fine. I'm happy with the answers, and we'll give
Thank you.
the word back to the prorector. Thank you.
Thank you very much. Then the opposition will be continued by Professor Lute Johan. He is involved in the Department of Clinical Chemistry at the Institute for Clinical Chemistry and Clinical Pharmacology at the University of Bonn, and I would like to also thank him that he joins today, and I give him the word.
Thank you, Mr. Prorector. Thank you for giving me the word. Dear candidate, I also read your booklet with great interest, and I'm connected with a group from Professor Shiri Svertlov since a longer while, and I really liked it to see the improve within the last year, though it was not a very easy time for you during the Corona period with all your studies. And you showed the nice results from the study on the robustness of the plasma acid phosphatase activity in adolescents and in adults with metabolic syndrome. And that is in the chapter 4, beginning at page 77. And the basic question, finally, for the quality of each clinical or epidemiological study is the determination of the sample size. How many subjects do you bring into your study? But I did not find this sample size. Usually you make a calculation before you start a study. Can you tell us a little bit, was there a sample size calculation that you just took this number of patients, or was the number of patients just given by the doctors that supplied you with the material?
Yeah. Highly esteemed opponent, thank you for your kind words and your question. So for this study, we do not have a large number of patients, and it's not depend on us to calculate how many patients. We did collaborate with the clinical clinicians, so they provide those cohort for us. And for the adolescents, we do not have that large cohort. That is one of the limitation. Yeah, we only have around 24 metabolic syndrome adolescents. So yeah, that depends on the.
But of course, it was also a first trial in these adolescents, so you did not have experience for special factors to calculate all this. I think that's also clear to understand. From this figure 1A on the page 84, we do learn that obese adolescents with metabolic syndrome present statistically significant higher plasma activity of acid phosphatase in comparison to obese adolescents without the metabolic. And the subjects, they were from the age, they were the same age in both groups, about 16 years old. So it's at the end of the puberty. And when you look at the activity, that's on page 80, on the same page, it is 1.7 or nearly twofold higher in the metabolic syndrome that you also showed in your nice slide. But from table 1 on page 82, you do find that there are only females in the group without metabolic syndrome, while in the metabolic syndrome group, we do find 40% male participants. So this is also mirrored by the HDL levels. So the HDL levels is always higher when you have females than males. So that's quite okay. But my question is now, could there be a gender specificity or a specific activity of this acid phosphatase finally leading to the higher activities in these groups?
I think it's possible. As you said, there indeed another limitation for the adolescent cohort. It's unbalanced sex, so we only have a female, we don't have. That is indeed a limitation. But I think sex do have an effect. It's possible has an effect on AP activity. Since from literature, so we see one of the specific isoform of acid phosphatase secreted from prostate. So that's think to have an effect.
Okay, thank you for your answer. And a similar question Now we go to the adult cohort. And this adult cohort is on the average about 3 times older than the adolescents. So, and on the other side, there is a 3-fold higher activity in the adult group without metabolic syndrome in comparison to the adolescent group. This is in figure 1A and B on page 84. So my question is here, could there also be an age dependency in the activity of this acid phosphatase?
Yes, I think so. It depends on the age because, as you said, in adults there are high amount of acid phosphatase secrete compared to adolescents, even triple, so 3 times. So I think age and sex relate to changes of activity of acid phosphatase, but still future study.
When you would like to plan a new study, so what would you propose for the members of the next study when you go? Now you have adolescents, now you have elder people. Perhaps you could plan for the future. What would you propose to include in the future?
Yes, I would propose, of course, a larger cohort, both on adolescents and adults, and with a balanced sex with both gender, and can compare the levels of activity of acid phosphatase both on adolescents and adults, and also we need to change sex and age if sex and age has an influence for AP.
Yes, and that's called that you merge the groups to identical. There was also a hint on the pharmacological treatment of the patients, and it was said on page 80 in the methods part that subjects taking intravenously applied drugs were excluded from the trial.
Sorry, could you...
in the methods on page 80, they said that subjects taking intravenously applied drugs were excluded from the trial. So that's a clear statement. So my question is now, what about those who took other drugs, not intravenously, but orally? So usually if you have high triglycerides, you should also be treated by some medications. So are these also excluded, or did you not look at the medication of orally?
I think this cohort, they exclude special drugs.
Independent of intravenously or orally applied?
Yeah,
Okay. Then I would, it's over?
Unfortunately, yes.
Yes, okay, thank you. You clearly answered all my questions. Thank you so much.
Fortunately, we have to give all members of the Corona 9 minutes. And we proceed now to online. Unfortunately, you cannot see it, but Professor Schram, involved in the Department of Diabetes Epidemiology at the Department of Internal Medicine at Maastricht University, will appear on the screen. And I would like to give her the possibility to discuss with the candidate. Professor Schram.
Thank you very much. Dear candidate, first of all, my congratulations with your thesis. And I would like to involve your supervising team in these congratulations as well. I've read it with great interest, and I was impressed by the translational approach. So taking into account combining human studies and animal studies. So I agree with you that chapter 2 was my favorite. So I will ask you some questions about this. In this chapter, you looked at the catepsin D as an early indicator for alcohol-related liver disease. And I was wondering about the way you assessed the alcohol intake. So you've used questionnaires to do this, but as methodologist, I know that questionnaires are usually prone to bias. So people tend to fill out what you would like to hear, not what is actually there. So I wondered what could you have done to improve this? Is there any blood test or breath test that could be a better indicator of alcohol intake?
Highly esteemed opponent, thank you for your kind words and your question. So for chapter 2 this study, actually we did not measure to test if patients are truly abstinent or not for this study. That is one of the limitation, but our following study in chapter 3, in that cohort, in a different cohort, we tested the alcohol marker to see if patients truly abstinent. And sorry, what was your next question?
So what type of test? I didn't hear that correctly, I think. So what test did you use in chapter 3?
You mean alcohol biomarker?
A biomarker, yes, indeed.
We used the UETG. HETG is also the very quick biomarker from hair or urine, and also from blood. So the marker from blood and urine, that is, can test the short-term alcohol. The marker from hair can kind of long-term for 6 months to test if you drink alcohol.
Okay, so that, and if you would have the chance, would you have liked to apply that in chapter 2 as well?
Yeah, of course. We will approve that for chapter 2.
Okay. So my next question is, this cathepsin D has been also associated to diet-induced steatotic liver disease in adults and children, and also with type 2 diabetes. So if you know this and you want to use this marker for alcohol or for liver disease, do you think it's specific enough?
I think it's not specific for liver disease, because in our group previous study also showed that cathepsin D is associated with type 2 diabetes and obese include the metabolic disorders. So I think cathepsin is not specific for a specific disease, but cathepsin indeed has a strong correlation with lipid accumulation and inflammation.
Okay. You also showed in abstinence after heavy drinking, there was no reduction in the cathepsin D levels. So how would you then interpret this result? Is this a marker of continued damage to the liver?
We found cathepsin D was even higher after abstinence, so would not indicate the liver get more damage. We explained that maybe because of hepatocyte proliferation, because after abstinence from patients, in my supplementary material did show their liver improved, and we tried to explain probably because of liver generation. So that is one of good signs to secreting more cathepsin D if hepatocytes proliferate.
Okay. What I also noted in this paper is that you sort of use a mixture of the pathophysiology thinking and the arguing for that, and then you also try to do some risk prediction. And at the same time, you also think about prognostic value. So I wondered if you want to progress this biomarker, what approach do you think is most promising? The detection, the prediction, or the prognosis?
So according to the dynamic changes of cathepsin D during the different stages of ALD, I would say it's possible that cathepsin D could be a prognosis indicator, but it's still need to test the cathepsin levels from the blood before treatment and also after treatment. If in a specific case on liver cirrhosis, we can say that before liver transplant or after liver transplant to see if there are significant change on cathepsin D.
Okay, thank you. I do have a specific question on figure 6 on page 42. Just looking it up. Yeah, so in this figure, you show the diagnostic value of adding cathepsin D to other tests that are used in clinical practice. So I wondered, based on the upper bars or the upper lines of this figure, what your recommendation would be in clinical practice. Would you advise to do cathepsin D alone, or would you combine it with any of the current practices like the AST and ALT measure or the transient elastography? What would your advice be and why?
I would not suggest to only use cathepsin D alone in clinic. I would suggest to combine cathepsin D also with other currently used biomarkers, like you said, AST, ALT, especially for liver biomarker. Also, TEs combined with imaging techniques and strong.
Okay, but what about using that?
Question? Because we have to proceed otherwise. Or you can stop, but
Okay.
I leave it to you.
Well, maybe I can stop now.
Whatever you want.
Answered my questions well. I'll give the word back to the prorector.
Thank you very much. Then we continue with Dr. Kramer. Dr. Kramer is a medical specialist in the field of gastrointestinal liver diseases from Maastricht University, and I also like to give him the opportunity to have a discussion with you. Dr. Kramer.
Thank you, Mr. Prorector. Dear Ms. Candidate, yeah, it's a great pleasure to be here today, and I also read your thesis with a great interest and pleasure. I would like to congratulate you and, of course, your promotion team with your achievement. You do know you're defending your thesis on Friday the 13th, and in Dutch popular culture that means that's an unlucky number. However, I think already you're doing a great job. So I think in Chinese numerology, number 13 is not so bad. And I looked at the number of chapters, and it's 8. And 8 should be the best number in Chinese numerology. So I think you should be fine today, right? So with that, we can start our discussion. And I would like to exchange thoughts with you about your work. And being a clinical doctor in the field of liver disease, I would also like to start with chapter 2. And in chapter 2, you describe the cathepsin D levels in healthy controls versus people with Met-ALD or ALD. And your healthy control group has been scrutinized. They got an endoscopy, they got extensive blood work, they did an ultrasound of the liver. But do you know anything about alcohol use in the healthy control group?
Esteemed opponent, thank you very much for your very nice kind words and your question. In chapter 2, for this study, this cohort we collaborate with our collaborators, so we did not measure alcohol acute biomarkers for these patients. So it is possible that patients are lying or did not report truly amount of alcohol.
So they were actually not forbidden to drink alcohol, which surprised me a little bit. So the healthy control group could drink 14 glasses of alcohol per week as a male, and as a female 7. And if I look at page 39, you have figure 2, and there you divide the ALD and ALD group in several groups, depending on the severity of liver damage or signs of liver damage. For instance, the level of steatosis in the pathology, in the biopsies, the inflammation scores, the fibrosis stages. And I was a bit surprised. You see that there's quite a number of ALD patients that have 0 steatosis, or that have zero inflammation or 0 fibrosis. So why did they end up in the ALD or ALD group? Because actually this group should have liver disease, either steatosis or something else, or should it just be people drinking but not having liver disease?
Yes, I think school 0, yes, indeed, they're drinking a lot, but without liver complications, if according to histological features.
Yeah. So if you then consider the healthy group being allowed to drink 14 glasses of alcohol, and in the ALD group having people without liver disease, how could it affect your data, the differences that you see? So you have a healthy group we think is really healthy, but they drink 14 glasses per week, perhaps. And we have an ALD group which perhaps doesn't have liver disease. If you would make your selection a little bit more strict, so healthy controls that don't drink, and ALD people with real liver disease, what would happen to your differences, you think?
For the ALD and ALD patients, their positions are heavy drinkers. So have a history of excessive drinking of those 150 patients. So yeah, we classified that due to the duration of drinking high amount of alcohol.
Okay. Correct. Yeah, I think your differences can be even stronger, right? I mean, I think you're contaminating your groups, or not you, but the groups that have been selected earlier are a little bit contaminated, perhaps. So the real differences might be even bigger. So, can I ask one of your paralymps to read out proposition 4, please?
Adaptions play a key role in the transition from NASH to HCC.
Okay. So, as a clinical doctor and Maastricht being an expert center for liver cancers, we see unfortunately quite a lot of patients each week. And in your thesis, you also described that liver cancer has a poor prognosis, which is absolutely true. So, of course, we encourage all studies that are leading to more understanding of the disease, and in order to make better diagnostic tools or therapeutic tools. And you say so catepsins play a key role in the transition from NASH to HCC. And in your chapter 7, you describe a lot of mechanisms in which catepsins could play a role in the development of HCC. Some of them are positive, some of them might be negative, promoting invasion or metastasis, for instance. But in the other chapters, you also describe different effects or associations. For instance, with increasing liver disease, Child-Pugh A, B, C, you see decreasing levels of catepsins. Suppose you develop the perfect catepsin inhibitor. In which patients do I have to use them? In the liver cirrhosis patients at risk for HCC, or in the early HCC patients, or in the patients with huge HCCs and metastasis? Where does it come in?
I think in our case for catepsin, you should use that during the early stages, including steatosis and inflammation. It has a significant difference. But for the advanced stages, not that need to use to detect cathepsin D. To detect advanced ALD, there's no need.
So that's about detection, but as a therapeutic tool, which patients would you give the cathepsin inhibitor to, or a cathepsin inducer, whatever you think is better?
Yes, for example, if in HCC, other cathepsins also has a potential use for cathepsin B. Yeah, actually there are more cathepsin BDSL also has a significant role in HCC, and there are multiple studies in vivo and in vitro studies show that inhibition of cathepsin B could be used treatment for HCC.
Okay, thank you. One short question?
Short.
Short. So, suppose you, next to the ideal therapeutic cathepsin B, a D inhibitor, you would have the perfect diagnostic tool, high sensitivity, high specificity, and you can use that in the alcoholic liver disease patients that drink significant amounts of alcohol. What would you tell a patient that has high levels of cathepsin D? What would you do differently in patients with high cathepsin D levels?
High level cathepsin indicates that there are lipid accumulation in your liver, and also followed by subsequently inflammation.
Okay. And what would you advise a patient regarding?
That was the last question.
Thank you very much. Perhaps we can talk later a little bit more.
I'm sorry.
More than happy to give the word back to Mr. Director.
Thank you very much. I would like to proceed, and I move to the last opponent, which is Dr. Thijs. He is involved in the Department of Precision Medicine at our university, and I'd like also give him the opportunity to discuss with you. Dr. Thijs.
Thank you very much, Prorector. And dear Mrs. Li, dear candidate, I also read your thesis with great enthusiasm, and it was a pleasure to read, and I would like to congratulate you, of course, also with the achievements as shown in this book, and with that also like to extend my congratulations to your promotion team, and actually also to quite some colleagues that are here that for sure also helped you getting these results. And it's probably not surprising that my questions are more related to cancer and to HCC, and I would like to sort of follow up on the questions of the previous opponent. Actually, do you think, in general, when you look at treatment for, let's say, HCC, that cathepsin D would be a good candidate to target?
Esteemed opponent, thank you for your compliment and your question. Yes, I would say yes, cathepsin D could be used treatment for HCC. However, it is a bit complicated. It has a difference between MASH and HCC.
Yeah, right, between MASH and HCC, but also because it is in the tumor, and you specifically, would you use like target the intracellular cathepsin D or the extracellular to start with?
I would use the extracellular cathepsin D because from our data, intracellular cathepsin inhibitor has a toxicity.
Okay, and follow up also on the previous opponent. There is, apart from cathepsin D, many other cathepsins, and in cancer, if you treat very specific, if you use targeted treatment, very often what you see is that after a while there's compensation mechanisms occurring in tumors. Here you have cathepsin from A to W, and almost all letters are a cathepsin. So aren't you afraid that if you specifically target extracellular cathepsin D, that would be not sufficient?
Yes, it's possible. If specifically inhibit cathepsin D, probably other cathepsins could have compensation effect. Other cathepsins express very highly. That is possible, but I think cathepsin D involved multiple cellular processing, HCC, like proliferation, tumor invasion, immune response, etc.
And then I was a bit surprised, or I'm wondering what your opinion is, because you show think in chapter 4, when you look at the treatment, like with the cathepsin D inhibitors, and you look at the lipidomics and so on, what you also see there is like you do see a decrease in inflammation, right? That is an observation that you make in that chapter. But is that something? If you would treat a tumor that you would like, a decrease in inflammation, maybe you want like the inflammation to be induced because you want to get rid of the tumor.
Yes. In MASH, indeed, we want cathepsin inhibitor reduce inflammation. That is a good sign and could improve liver symptom. But in HCC, we do not actually want to inhibit inflammation and immune cells, because in HCC we want immune system and immune cells to fight with the tumor cells. So it's a bit complicated.
Mm. And maybe to add to that complexity, or maybe to make it more simple, rather than targeting specifically cathepsin D, how about we use a pan inhibitor, so that targets all of the cathepsins, if that would exist, at the same time?
So pan inhibitor, if inhibits all cathepsins, indeed it is easier. So no specific cathepsin. However, it also has disadvantages if inhibiting all type of cathepsins, because cathepsin is secreted by all type of cells. So it's present all over the body. It could function the physical environment under normal condition. If inhibit all type of cathepsins, it would lead to dysfunction of normal cells. So I would not suggest use that for human.
Okay. All right. And then I was wondering, and it has been touched upon slightly. I wonder if you would do a treatment, or let's say diagnosis. You would like to do a diagnosis, and you check cathepsin D levels. How would diet influence that diagnosis? Because patients come, and they come to the clinic, and cathepsin D levels are being measured. But how reproducible are these results? Because I can imagine a few reasons how diet can influence these levels, for instance.
Yes. So for the diet, for example, cholesterol indeed have a big impact on cathepsin D. If for patients, we could measure cathepsin D from the blood at the same time, routinely every day from patients to compare to say if the specific diet combined with the cathepsin D have an effect on patients.
But what if it would be like a routine test in the clinic? Wouldn't you advise patients before they come to the clinic for a certain period to adhere to a certain diet, or to prevent having certain, whatever, high-fat diet, for instance?
Yes, I would suggest the patients recommend some low-fat diet, I would say. For a period, and measure their blood routinely to see the effect.
Okay. And then it was a question that came up during the presentation and during the question of my colleague here on the AP levels that you measured, and it was asked, what is the influence of sex or of age in these measurements? And I was wondering, what if you would do this with cathepsins, that same study? What would be the influence of age and or sex on cathepsin levels? Would it be similar? Do you have an idea?
There are influence of sex and age on cathepsin from literatures. It shows that cathepsin D is a downstream of estrogen, so it did influence sex hormone. So for my study, I would correct age and sex. To say if age and sex influence conception D.
Horen eens.
Okay, with this, I have to give the word back to the prorectors.
Thank you very much. And there was basically you finalized your answer. So, or would you like to add something to our opponent?
Thanks. So from literatures, we say that age and sex related changes in activity in conceptions like conception B and conception D. So that is a good point. If for the future I do my analysis, I would correct age and sex to say that if they influence conception D.
Thank you very much. This concludes this defense. So, Mrs. Li, the time appointed for defending your thesis has now passed. The degree committee will discuss now the quality of your thesis, which already has been approved by the assessment committee, but we're going to discuss the way you have defended your thesis this afternoon. And I would request that you and your company will leave the room so then we can discuss, and we, the Beadle, will ask you back in as soon as we have finished our deliberations. Thank you very much. Okay.
In front of me, please. U kunt wel plaatsnemen.
Dear Mrs. Li, the degree committee here present has discussed the way you have defended your thesis, but also the way your previous thesis itself, and also the presentation you have given today. In view of its positive verdict, and taking into account your previous qualifications, the degree committee has decided to grant you officially the degree of doctor. Compliments. Professor Shri Svetlov is authorized to confer upon you this academic distinction in accordance with Dutch university law. And I invite your supervisor now to take the floor.
Wilt u gaan staan?
Do you promise to work in accordance with the principle of scientific integrity at all times, to be careful and honest, transparent, independent and responsible?
One moment. She has to speak because it's recorded officially. Say yes, loudly.
Yes.
By the authority vested in us by law, in conformity with the decision of the committee here present, I hereby confer upon you, Mengying Li, the degree of doctor, and grant you with all rights attached by the customs and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university.
If there's a photographer, he can come forward. Okay, there she is. Very good.
U kunt wel plaatsnemen.
And I'd like to give the word to the first promoter, Professor Shri Svetlov, who will give the laudatio.
Dear Mengying, dear Dr. Li, what a huge pleasure it is to be the first one to congratulate you, to call you by this title. And I'm not just congratulating you on my behalf, but also on the behalf of the entire promotion team, so Tom and Marit, and also your daily supervisors, Albert and Dennis. We are all very, very proud of you. And if I have to define one word that is associated the best with your PhD track, this word for sure will be challenges. From the very first day to the very end, your path was full with challenges. And this is excluding Friday the 13th. You started 4 years ago when the world was busy with one of the biggest challenges of modern society. That was the COVID pandemic. And back then we tried to convince you, of course, to postpone your arrival to the Netherlands. But you insisted. And the fact that the world was just stopping didn't stop you, didn't make you change your mind. You are not the type to let a small virus interfere with your big plans. So what you did was you were in isolation 4 weeks in China. And after these 4 weeks, additional 2 weeks here in the Netherlands. And as much as I hate to say it, another extra week simply because we were terrified back then by meeting anyone that came from international flights. And after this, the labs were closed, so everything started online. And you know, when we think about it from a practical point of view, of course, that's very difficult. But if you really think about it, like moving to another continent, leaving your family behind in a time that, yeah, there was so much uncertainty and fear in the world. Wow, I know very little people who will do that. I mean, you are extremely brave and you face this challenge with a lot of strength and determination and grace. And I think these are the same characteristics that helped you throughout the entire PhD track. Because of course in every PhD track there is a lot of challenges, that's inherited. But you had also a lot of additional personal challenges. And you didn't let anything stop you, nothing stop you. So not the language barrier, the cultural differences, not even the fact that you needed to take an additional side job aligned with your PhD. I want to say not even the Dutch food, but here it's like borderline, almost broke you. But still, you are so much more than deserving this diploma that you worked extremely hard for. And we are very happy with that. And not only that you finished on time, but actually you were able to somehow combine it with your biggest hobby, that is traveling into European cities. And you have seen, I think, more European cities in the last 4 years than all of us together our entire life. This is really impressive record. And yeah, this is really nice to see. And actually, very recently when I asked you what was the best part of your PhD, I don't know if you remember your reply to me, but what you said was exploring European cities. Well, I don't know what it says about us, probably not the biggest compliment. On the other hand, well, Northern Lights, us, I would also select for the Northern Lights. But I think this is great that you've done it. And well, along the years, we've really enjoyed so much seeing you growing as a person, but also with your confidence, but also as a scientist. You know, you have learned to ask critical questions and to see the bigger picture. And also you have learned sometimes to take the lead when necessary. So for example, when you struggled a little bit with analyzing your data, you have decided to take an R course so that you can do that by yourself. And we really appreciate it a lot. But of course, you know, in 4 years, you get to know a person more than just the scientific skills. So it's also about the personality. And it was absolutely joy for us to work with you. There is something about your character that is what I call quiet strengths that left a big impact on all of us. You're very kind, you're very warm. You enjoyed very much, for example, sharing Chinese dishes with us. And each and every time you traveled to China, you made sure to bring us present, but not just present, personal presents to each and every one of us, including when your husband came here, he also needed to fill his suitcases with presents. I think you packed so much that he had no place in a suitcase for his own things. So this is just showing us your generosity. And also, well, I do have to mention it, during our last departmental trip, that was coincidentally we all discovered that you have these amazing talents in playing the piano. And it was not just playing the piano, I mean, this was really beautiful and so professional. All of us were so emotional, like all of a sudden there was a quiet in the room and everyone were listening to you. And when we gave you compliments, you were sort of like brushing us off as if this is not that important. And I think this is an indication for how modest you are. And that was really nice. Mengying, you have passed so many challenges to come to this point, and I'm therefore sure that no matter which challenges you will have in the future, you will be able to overcome it with the same determination and grace that you have. I would like to congratulate you today on this very nice day to celebrate on behalf of all of us with your degree, and also to congratulate your family that unfortunately are not here yet, but they will soon come to explore together with you additional European cities, if there are any left. And yeah, I wish you lots of good luck, and I hope we will keep in touch.
Thank you.
I would like to give back the word to the pro-rector.
Thank you very much. So, Mrs. Li, dear Dr. Li, how does that feel?
Very good.
That's the way we like to. That's the way we like to hear it. So, Dr. Li, I would like to congratulate you on behalf of Maastricht University, of the board of directors of university, and I would say you did a great job. We came to a unanimous positive decision, and everybody was surprised about the quality of the answers you have given at your defense. So that's a compliment. I'm not going to speak again what already was mentioned by Dr. Kramer. That's today. It's the Friday the 13th. It's also 1300 hours where you started here. So you have another 13 in your time. But I'm also very pleased, as previous responsible for the CSC program, that you really did a very good job as CSC students. And I know that we have to stop the program now for 1 year because there were financial issues. But to be honest to you, you mentioned there were financial issues. but you visited a lot of European cities out of here. So there is still some money left over to visit a lot of European cities. And I'm going to discuss this with you a little bit at the reception. I know it's also in the program that you have to go back to China for 2 years to do voluntary work or basically work which is associated with that. But I noticed that most of the PhD CSC students like to go. Some will remain and some can even come back as postdoc in a postdoc CSC program. I wish you all the best, and I think the future looks very bright for you. I continue a little bit. So I also like to continue in my congratulations to the promotion team, who really worked with you in the last 4 years and who brought you to this point. I would like to thank them also on behalf of Maastricht University. And then my thanks also go to the members of the Corona, who basically had just 9 minutes, but it took them much more time to travel or to prepare, to read your thesis here. And I'd like to thank them for them. The audience, I also like to thank that they joined us today in this small area here. And I think it's time now for some celebration. And for that, officially I'm going to close this. I use my hammer, which I have here. And officially I close this ceremony. How do we proceed now? We're going to make a picture here. This is a little bit difficult here, but we like to make a picture together with Professor Schramm. And the beadle knows exactly